in that. Right, almost similar it is. So divergence insufficiency and a convergence excess, the symptoms and signs are almost similar. So can any one of you just quickly tell that how to diagnose that? Yes. So basically, anyone will try? Yes, anyone wants to try? How to diagnose this divergence insufficiency and convergence excess? Anyone want to try?
Ma'am, the convergence excess can be diagnosed if we see according to these signs, the exophoria is more for the distance, and the PFB is high and low NFB.
Okay.
These are the main, and even the MPC is lesser than 6 centimeter to till the nose. These are the signs that we can see for
Notice your mic has been got muted. Yes, your mic has got muted. Yes.
Oh, yes, ma'am. Ma'am, and then we can even see the amplitude of accommodation is normal for the convergence axis.
Okay.
These are the four parameters or the signs that we can see for the convergence axis.
Right. So basically, the main difference between a convergence excess and a divergence insufficiency is that there is in a divergence insufficiency, what is there? Divergence insufficiency, the patient means that the patient cannot diverge at distance. So the distance esophoria will be more than the near esophoria. So divergence insufficiency patient can either have a esophoria at distance or an esotropia at distance. They can have like that. So the distance esophoria will be more than the near esophoria in case of divergence insufficiency. So basically divergence insufficiency means the patient cannot diverge. So we can keep in mind, yes, that the phoria should be like an esophoria. It should be esophoria because the patient cannot diverge, right? So that is the case. So in divergence insufficiency, the esophoria is more for distance than near. Okay. But in convergence excess, what is happening? Convergence excess, there is esophoria because convergence is more. So more esophoria is there for near, or the patient might have a esotropia at near also. Okay, so those patients will come with a complaint of convergence excess. So convergence excess basically in children who have a congenital esotropia or an accommodative esotropia, so we'll find a convergence excess in those kind of children because they're having too much of ESO at near. So that is the thing. So all the Vargens parameters, what we have discussed. So when we are doing an orthoptic evaluation, complete orthoptic evaluation, when we are doing it, we'll get there is the Vargens parameters will be decreased. The NFV, PFV, and the NPC and all that will get affected. So for convergence excess, the NPC will be normal because the patient is having normal convergence. There will be reduced negative fusional Vargens will be there. Positive fusional Vargens will be normal for convergence excess. Negative fusional Vargens will be less for convergence excess, and the PRA value will be also less. Why less PRA value? Because I have discussed that in case of Divergence anomalies also, while measuring, while doing the orthoptic evaluation, some parameters indirectly measures Divergence anomaly, Divergence also, like the NRA PRA. Okay, so NRA PRA is basically a test for measuring accommodation. NRA is a negative relative accommodation, means you are putting plus lenses and seeing like how much the eyes can relax the accommodation, that is the NRA. Okay, so how this NRA is related, how this NRA is related. So what we have discussed in the previous class, this is very important to note that whenever we have been given any near target, we have been given any near target to see, first our convergence will act. Okay, so I will try with my positive fusion. Suppose there is a near target even at 40 centimeter. Okay, so first my positive fusional divergence will work. Okay, so I will try to fuse and make it single and have a try to see that image to be single and clear. Okay, so when my fusional divergence reserve gets exhausted, then only my accommodation will work. So for a near target seeing, my accommodative convergence will work. For seeing a near target, my accommodative convergence will work. So first the convergence parameter will be used, and then we will use our good morning. So then we'll use our accommodative parameters. So accommodative reserve. First our divergence reserve will be exhausted, then my accommodative reserve will be exhausted. So how this negative fusional divergence and PRA is related? How this negative fusional divergence and PRA is related? Anyone will like to try? Yes. How the negative fusional divergence and PRA is related? Okay. In negative fusional divergence, how we are measuring the negative fusional divergence? We are measuring the negative fusional divergence with the help of basin prisms, right? We are seeing that how how much our eyes can diverge. That is our negative fusional divergence. Okay, so our eyes, how much it can diverge. So when we are measuring the PRA, how the test is done, the PRA, the positive relative accommodation test, is being done with the addition of minus 0.25 lenses. Okay, at every click. Okay, so we are adding minus 0.25 lenses and giving a near target at 40 centimeter and seeing how much the patient can accommodate, how much with the highest amount of minus lenses. So that is the limit of positive relative accommodation. So suppose the positive relative accommodation is coming to be minus 2.5. So that means the patient can accommodate till minus 2.5. Minus 2.5 diopter lens the patient can accommodate. So what I've discussed that while doing like any test for accommodation, first my divergence reserve will be used, then my accommodative reserve will be used. Okay, so you are putting minus lenses. What is happening? Your eyes are forced to come like this, right? You're putting minus lenses to stimulate the accommodation. Your eyes are forced to come like this. Now you have to balance that movement. So your eyes needs to be straight. Okay, so if the eyes are forced to come like this closer together, now to balance that, what is happening? You are going to you have to make that eyes to be straight. So this movement will be there. So the from the like this position, the eyes will go like this. Okay, so that is a measure of my negative fusional divergence, right? So this convergence excess, what is happening? The patient will have a reduced negative fusional divergence because the patient cannot have less amount of divergence capabilities, so the patient cannot diverge properly. So that's the reason there will be a reduced NFP, and also there will be a low PRA. Why a low PRA will be there? Why? Because that is PRA is an indirect measurement of the negative fusional divergence. So if my negative fusional divergence is low, automatically there will be a low PRA. So along with the divergence parameters, there will be also like the some parameters like the NRA PRA, the MEM value. These some of the parameters will be affected a little bit. That is the thing. So we have discussed. Any more questions from this part? We have already discussed this. So divergence insufficiency, convergence excess we have discussed. We have also discussed divergence excess and fusional divergence dysfunction. So in divergence excess, there is a greater exophoria or the intermittent divergence screen for distance, and near there may be a exophoria, but near exophoria will be much lesser than the distance exophoria. So mainly this patient's divergence excess patients comes with a with a complaint of exotropia distance, means that when the patient looks at distance, the eyes will go out like this. So this patient come with the typical sign like this, that the patient when he looks at distance, the eyes will go out. So that is a intermittent divergence squint, because sometimes there is exotropia and sometimes there is not. So that is the intermittent divergence squint. So for divergence excess, basically the patient might have a intermittent divergence squint for distance, or a greater exophoria for distance. Near also there will be a exophoria. Mostly there will be exophoria. Exophoria will only be there for normally for divergence excess. So but the distance exophoria or exotropia is much greater in case of divergence excess than the near ones. Okay. So how to treat that? How to treat that? If the patient is having an exotropia for distance, okay, first we need to make the eyes straight, right? So eyes have been diverged like this, the eyes have gone out like this. So we need to first treat that eyes to make it straight. So what we'll do, we'll train the distance and intermediate part first, then we'll slowly come to the near one. Okay. For convergence insufficiency, ulta we do, means opposite thing we do. For convergence insufficiency, we'll treat the near exophoria or exotropia and then go slowly to intermediate and distance. But for divergence excess, we have to treat the distance exotropia or exophoria first. How can we do that? Suppose a patient is having a so you are doing a prism bar cover test and have measured the distance exotropia. The patient is having a distance exotropia of about 20 prism diopter at distance. So definitely he cannot fuse at distance. His eyes will always go out like this. So how to train that patient? Okay, first we train this kind of patients with the basic, very basic exercises like the Broxting exercise. We can train the patient with the help of the very basic exercises. Okay, so for 20 prism exotropia at distance, you cannot expect the patient to fuse at distance. So how can we do the treatment? We do an in-office treatment. In-office treatment means wherever in your in your clinic you are practicing, so you are giving vision therapy in your clinic, means that is an in-office treatment. So first we need to give an in-office treatment. How to do that? If the patient after repeated trials also cannot fuse at all for distance, we will give some relieving prism for the patient to fuse at distance. So for the Broxting exercise, there is a last bead. So when the patient is looking at the last bead, there will be a A pattern. Now the problem with the patient is the patient cannot look at the last bead or cannot fuse the last bead. Okay. Now you can need to give some kind of relieving prism to help the patient. Relieving prism and exercising prism, let me just discuss. So relieving prism means relieving prism means which relieves the cause. So for treating exotropia, the basin prisms are the relieving prisms, and exercising prism means which will increase the difficulty level. So exercising prism for exotropia will be the base out prisms. So here in this case, where the patient is too much exotropic at distance, the patient cannot be managed or controlled, we need to give a relieving prism. So for 20 prism exotropia distance, maybe we are trying with trying the patient to give 10 prism basin. So you can give a 5 prism basin in the right eye, 5 prism basin in the left eye, and tell the patient and like motivate the patient to fuse at distance. If the patient now can fuse at distance, because you have put the relieving prisms, now the patient will be able to somewhat fuse at distance. So try and see how much the patient is improving. Now you make the patient do the exercise with putting the relieving prisms. Now the patient can fuse at distance and maintain fusion for some moments. Okay, the thing is that if you can maintain fusion, for longer duration, okay, so that will actually improve your fusional Divergence reserve. That will improve your fusional Divergence reserve. Any questions?
Ma'am, the convergence insufficiency and the divergence excess is same or not, ma'am? But the
No, it is not.
symptoms are quite similar.
It is not basically same. Divergence excess and convergence insufficiency, the signs will not be same. The symptoms will be somewhat same. Okay, the symptoms like the headache, the asthenopic symptoms, difficulty in breathing, difficulty in daily lifestyle, that will be, the symptoms might be same. But the science is that when we are testing the phoria, we can test the phoria with the help of Maddox rod. We can test the phoria with the help of Maddox rod. So with the Maddox rod, when we are testing, in case of a divergence excess, we will get the amount of exophoria for distance will be always greater compared to the near exophoria. But in convergence insufficiency, the amount of exophoria for near will be always greater in case of convergence insufficiency. So that is a main difference. Also, like in an excess case, divergence excess means high ACY ratio. Okay, convergence insufficiency means low ACY ratio. All these things will be also there. So these difference you have to understand. So when we are treating the patient, first we have to identify what is the problem of the patient. Accordingly, we have to treat. Okay. Suppose a patient is having only problem for distance. He cannot fuse at distance, but near he can manage, he can read, he can do all these things. He does not have any problem. So for distance, if the patient is having problem, we need to train the distance first. We need to train the distance fusion. Means we have to train the fusion at distance basically. Okay. Is it clear now?
Yes, ma'am. Thank you.
Okay. So also we have discussed about the fusional Divergence dysfunction previous day. Fusional Divergence dysfunction means all the accommodation and the convergence parameters will be low. This case is very less, like very rarely we see this fusional Divergence dysfunction in our clinic. Okay, because accommodation, convergence, everything is low in this case. Fusional Divergence dysfunction. Okay, so the patient may be ESO or exophoria. There will be reduced NFV and PFV at distance and near. There will be NRA, PRA, both will be low. Okay, accommodative facility, the patient cannot clear both the plus and minus lenses. Okay, so basically binocularly the patient will have more problem in case of fusional Divergence dysfunction. When we check the accommodation uniocularly, very rare case actually, we get very like in a 1 in 50 cases or 1 in 100 cases maybe we'll get in a fusional Divergence dysfunction. So when we are checking the accommodation monocularly, the accommodation is normal. Okay, but when we are checking it binocularly, it is abnormal. He cannot clear the plus or minus lenses in the accommodative facility test. Or if you are measuring the negative fusional Divergence and the positive fusional Divergence for distance and both, everything it is lesser. Everything it is reduced in this case. So it is very, very difficult to treat this patient basically. Basically, it is very difficult to treat this patient because you cannot give a plus lens therapy. Only thing you can give, like you can train the vision. You can do the vision therapy at your clinic and see if the patient is improving or not. Okay, so whatever may be the patient's problem, we always try to treat the cause. Okay, we have to find the cause before that. That's why I'm taking this class. We need to find the cause. What is the exact binocular vision anomaly for the patient? That we have to find out first. Okay, then only we'll go about with the treatment options. Is it clear to all of you? Any doubt? Any doubt in this? Anyone having any doubt? Okay. So basic exo and basic ESO we have also discussed. The basic exophoria or basic esophoria, both the phoria for distance and near, it will be same for in basic exophoria, the exophoria for distance and near, it will be same. The PFV and Warden's facility and distance and near, it will be less. Low NRA. Accommodative facility, the patient will cannot clear the plus. Fails accommodative facility with plus. Basic esophoria, definitely the amount of esophoria, main thing for basic esophoria, amount of esophoria for distance and near, it will be same. So if we measure it with a Maddox rod, we get the same amount of esophoria for distance and near. So the patient will have less negative fusional margins, okay, at distance and near both, because both the amount of esophoria for distance and near, it is same. So NFV will be less for distance and near both when we are doing a step Divergence testing. PRA will be also less, and the patient fails accommodative facility with minus lenses. So basic esophoria, basic exophoria also we get very less amount in compared to the other cases. Because it is like a concomitant squint actually. Concomitant squint, no? Concomitant squint, you know that the amount of tropia is same for like all the gazes, right? So like that, it is around that, like that. So basic esophoria or basic exophoria, amount of exophoria is same for both distance and near. And esophoria, the amount of esophoria is same for both distance and near. So the patient will have problem with both distance and near. So if these cases we get in our clinic, we have to train both distance and near. We cannot train one single part and then leave it. Okay. So if the patient is having a basic exophoria, we have to do like train the phoria status at distance and near both. That is the thing. Okay, so we can do it with a, can start with a, like always we start with a basic exercise like the Brock string. Okay, if the patient is doing well, then you move to, you can do the Brock string and cat card exercise also you can give. So if the patient is doing well, then we move to the eccentric circles. You can move to, before eccentric circles, you can start with a lifesaver card. So we train with the Brock string first, Brock string cat card, then we train with the lifesaver card. Once a patient can do it, then we can train with the eccentric circles and the other higher versions like the tranaglyphs and all. But tranaglyphs always, it gives a very good result because there is like both the peripheral fusion and the central fusion, both things are trained. So this always gives a better result. So this way we need to train, we need to give time to the patient. See, if the patient is having any BV anomaly, binocular vision anomaly, the patient cannot be cured in one night, right? Or in a 1 week's time, the patient cannot get cured. It can take months to get recovered. Yes. So it can take 1 month's time to get recovered. It can take 3 months time to get recovered. It can take 6 months time to get recovered. Also, once recovered, the patient can get back the symptoms again. So to stop that, to stop recurrence, we need to, once the patient is well conversant with the exercises at your clinic, means the in-office treatment the patient is good conversant with, then you give the home vision therapy. So also we give some kind of home vision therapy for the patient, so that if the patient is practicing at home, he will not, probably not going to get those symptoms again. So that is the thing. Now we'll start with the accommodative anomalies. Okay, so accommodative anomalies will be starting with. So coming to accommodative insufficiency. Coming to accommodative insufficiency. Accommodative insufficiency. What are the symptoms and signs? The symptoms are similar to presbyopia because the patient cannot accommodate. So normally we get a low, like if we measure the amplitude of accommodation, we'll get a lower amplitude of accommodation. So symptoms of the patient, it will be symptoms to like clear, like presbyopia. The patient will have difficulty to read. The patient will cannot sustain near vision for a longer period of time. So this may be the problem with accommodative insufficiency. The patient may have a blurred near vision. The patient may have discomfort, strain, and fatigue on near what. Okay, so prolonged hours of reading, the patient will get too much of headache. The patient cannot concentrate. Patient has come to your clinic now. Now it is your duty to test all the parameters in while doing the orthoptic evaluation and find out the cause. Okay. So coming to the signs of accommodative insufficiency, what will be the signs of accommodative insufficiency? There will be a reduced NPA, that means the near point of accommodation will be reduced. Okay. If you are measuring the amplitude of accommodation, that will be reduced. Amplitude of accommodation, if you are comparing with the Hofstadter's formula, Hofstadter's formula is 18.5 minus 0.3 into age. Suppose a patient is having a 10-year-old child, means 0.3 into age means it's like 0.3 into 10, that means 3. So 18.5 minus 3 is 15.5. So 15.5 should be your amplitude of accommodation. Okay. So the patient will be having lesser amplitude of accommodation as compared with the Hofstadter's formula. That is the main thing in accommodative insufficiency. Okay. So NPA, AOA means amplitude of accommodation, both will be lowered. Also, the patient, when we are doing MEM retinoscopy, when we are doing it, the patient will have a higher lag of accommodation because the patient's accommodation is less. So higher lag of accommodation the patient will be having. So maybe a +1 MEM, we can get a +1 or a +125 in MEM retinoscopy. When we are doing a accommodative facility testing with the help of accommodative flippers, the patient will have difficulty to clear the minus lenses. Okay. Minus lenses the patient cannot clear because the patient cannot stimulate the accommodation. So when we are putting the minus lenses, means we are stimulating the accommodation, so the patient cannot stimulate the accommodation. That is the reason the patient cannot clear minus lenses in facility testing checking. Also, when we are doing the NRA PRA testing in case of accommodative insufficiency, the negative relative accommodation, that is the NRA value, will be normal. Means we are testing with the plus lenses and we are seeing how much the patient can relax the accommodation. So NRA will be normal, right? But when we are doing the PRA testing with the minus lenses, minus 0.25 we are adding, we see that we will see that the PRA value will be low because the patient cannot clear those minus lenses. Is it clear to all of you? Any doubt in this accommodative insufficiency, how to diagnose this case? Okay. Okay. So mostly, like the main thing means whenever a patient comes to a clinic, we think that either the patient will have an accommodative insufficiency or a convergence insufficiency. That is our mindset. That is the reason, like many students doing the orthoptic evaluation test, they are diagnosing the case as accommodative insufficiency or a convergence insufficiency. See, convergence insufficiency is very common. Even accommodative insufficiency is also common. Okay, but all the parameters we need to check. We need to cross check. We need to do the amplitude of accommodation test. 3 times at least. When we are testing the near point of convergence, that also we should do 2 to 3 times. Okay. Also, when testing the near point of convergence, we should take the objective measurement as well as the subjective measurement and compare and see. And we should see whether the NPC is getting receded with repeated trials or not. Similarly, with amplitude of accommodation also, first we have got suppose 12 diopter. Second time we are doing means we are getting a 11 diopter. Third time 10.5 diopter. Like this means the amplitude of accommodation is receding. So this trend also we need to find out. Actually, minimum 45 minutes you take to do a complete orthoptic evaluation in your clinic. Okay, so these things needs to be done very properly, otherwise you will end up with finding a wrong diagnosis and will give a wrong treatment to the patient. So those things should be avoided. That is the thing. Okay, now coming to accommodative excess. Accommodative excess means the patient is over accommodating. The similar to the symptoms will be the similar to accommodative insufficiency, like the headache, too much of eye strain, the patient cannot concentrate for long. So those things will be there. Okay, but the signs will be completely different. When you are checking the amplitude of accommodation, suppose the patient requires 12 diopter of amplitude of accommodation, you are getting a 13 diopter or a 14 diopter, okay, or a 12.5 diopter. Means 12 diopter is required according to Hostatus, means 12.5 diopter means it is a accommodative excess. No, not like that. You need to recheck. You need to recheck. Okay, so 3 times at least you need to recheck to confirm the condition. Okay, so the amplitude of accommodation will be normal or a higher in case. MEM value, the main thing where you find the difference in the MEM value. If you do a proper dynamic retinoscopy, you will find a lead of accommodation in case of accommodative excess. So when you are doing a MEM, you should get a plus 0.5 or a plus 0.75 lag of accommodation. So in this case of accommodative excess, you can get a plus 0.5, plus 0.25 or a 0, or in the minus side you can get it. So the MEM value will be low. That means there will be a lead of accommodation in the MEM dynamic retinoscopy testing. Okay, amplitude of accommodation will be in the higher side. NPC will be normal. When you are checking the NRA-PRA means you are testing how much the patient can relax the accommodation with the help of plus lens. So here the patient cannot relax the accommodation. That is the main problem. The patient, the PRA will be normal or more. The stimulate the accommodation maybe, it may be 3 minus 3, the PRA may be minus 3, minus 3.5, minus 4, minus 4.5, minus 5, minus 6, whatever it is, you will get a higher PRA value. But an NRA value will be much lesser compared to the PRA value. That means the patient can stimulate accommodation to a greater extent, but the negative relative accommodation means the patient cannot relax the accommodation to the same extent. So you will get a reduced NRA in case of accommodative excess. And also, if you are testing the accommodative facility testing, when you are doing with the flippers, you will be facing it hard. The patient will face, means it will be very hard for the patient to clear the plus lenses. If you are getting a NRA around plus 125 and PRA about minus 5, means you can understand, if you are trying with the plus minus 1 clipper also, the patient will find difficult to clear the plus 1 lens. Minus lens he will be easy to clear. So accommodative excess should not be also mixed with accommodative spasm, because accommodative excess can be cured too long, means very easily it can be cured. Accommodative excess can be cured easily, but accommodative spasm means it is related, also it is related with convergence spasm. We need to give like drugs also. We need to, drugs means the atropine eye drops and all, maybe oral also we need to give sometimes. So it is, the treatment is completely different in case of accommodative excess and accommodative spasm. So like we need not like we should not in fact we should not get confused with these two parameters. Okay. Any questions? Any questions till this? So we need to like differentiate between accommodative excess and accommodative spasm, because both the treatment options are different. That is the thing. Because accommodative spasm means the patient is the highest stimulated accommodation. The patient has reached the highest stimulated accommodation. He cannot come back to normal. But for accommodative excess, if you are giving some stimulus, he can come back to normal. So that is the thing. That is the difference with the spasm and excess case. Any questions with any one of you? Any questions do you have? Otherwise, we'll close the session here. Any questions if you're having?